Right. So we are live, and hey, audience on YouTube. So this is the panel that we have here, and we'll start the event in another 8 minutes, to be exact. So Pawan, Dr. Powderly, and Jason, do you have anything to say to the around 15 people who have joined us right now early?
Looking forward to this discussion.
Yes, welcome from North Carolina.
So, if again, those of you who are early, you can just let us know in the comments, where you're from, where you're joining us from, what you do. And if we find the comment is interesting, I will put it out on the screen and I'll read it out. So, Jason, where are you joining us from again?
New York at the moment.
New York.
Yeah.
Excellent.
Usually based out of San Francisco, but New York at the moment.
Excellent, excellent. And I am joining from India, Bengaluru. So everyone else in the US. Right. Another 6 more minutes and we'll begin. All right. So it's FHIR Media. I'm here. Hi from South Africa. Hi, nice to see you. Let's see, I'm not sure the geography of the people who will join us today. So the registrations were mostly US, but yeah.
I think that's one of the interesting things about FHIR and the HL7 standard, the fact that it's an international body that's kind of coming together to define these standards and these specifications. Yeah, I'm very interested in how interoperability will kind of work in the future as countries, Canada, the UK, Australia, start opening up their patient access APIs.
Exactly. This is Andy from the UK says hi. Hi, Andy.
Yeah, I think if we learned one thing from COVID is like, healthcare doesn't know borders. So definitely, that taught a lot of lessons. Added accelerant to the fire.
For sure. And I think that's the other thing, right? So these big EHR vendors, they are actually being implemented internationally. So they're kind of like exporting the standards outside the US. So this is Rasail. Hi from Bangladesh. Hi. I mean, we've already covered half of the other side of the globe now. Yeah.
So Sidharth, are you seeing some of the American vendors then for the big systems, the oligopoly systems? Are they also penetrating into the other corners?
Yeah, for sure. I think in India, Cerner is a big player. And in Singapore, we know that Epic is big.
Epic.
And again, like people who've joined us already, let me know in the comments, like what is your, what big EHR vendors do you have? Is it the same as the US? Is it different? But yeah, definitely I can say that Epic and Cerner are present worldwide.
Oh, okay. I think that's one of the interesting things about these. Another interesting thing about the patient access APIs is that, as these software vendors, these massive corporations are implementing patient access APIs, theoretically, other countries and health systems can just turn it on by toggling a switch, right? The APIs already exist, the work's already been done. As long as the legislation passes or the health institution themselves decide that they want to enable this functionality, they can do so because the EHR systems already support it.
Right. I mean, this is the major EHR systems supported, but as we will see, there are problems with these major EHR systems as well, which we'll probably discuss a lot more about.
Sidharth, have you heard, are any of them so far aligning with the momentum of the Federation and the data sharing at the government level on certain standards, like openEHR or FHIR standards?
Bigger ones in the US, no, not really. But we are seeing a lot more in the European side, which are kind of aligning, like especially since a lot of governments went full in on these platform APIs, right? I think Sweden is a big one, Spain is a big one, the UK is also a big one right now with the whole One London initiative based on these. So Andy says in the UK you have Epic, Cerner, Meditech are the major hospital EMRs in the UK. That's exactly the same as the US. So
Yeah.
that's like, yeah.
Yeah. I actually read a very nice report. I'll share it if I can find the link on UK, how they are implementing they've proposed a system to NHS for a nationwide exchange and like patient exchange and everything. So very interesting how, they're trying to move towards it too.
Yeah, I mean, hopefully the oligopoly does not does not block this.
Learn from the mistakes here.
Yeah, I wonder what the physicians think of that, and I wonder if there'll be some physicians on the call. That would be good to hear their perspective. They're practicing outside the United States.
Yeah, I suspect there will definitely be some clinicians and physicians joining us today, and it'll be interesting to see what EHR they are using and what they've been doing. So it's almost time. It's 1 minute to go live. I think let's wait for 1 minute and then we'll start exactly on time. Yeah. Any physicians again from the audience today? Any physicians joining us today? So from South Africa, there's nothing in South Africa. I'm busy working with the government to start implementing it. We are so far behind, but giants like you are making it easy for us to adapt. Yeah, I think there is a lot of momentum in developing nations. And, I think we need to get it right the first time instead of like making mistakes again and again. And then we should learn from the other countries.
It's kind of easier, better, right? Because they're not dealing with legacy problems.
Yeah. Learn from America's legacy problems.
That's the, hey, we learned it over 2009 we started it. So now we are fixing it. We're already in that second and third cycle. So
yeah. All right. So we are live and we have started before time, but so this is a panel discussion on the API advantage and why, data platforms are revolutionizing how healthcare is done in the US. So first, let's start off with introductions. So I will start with myself. So I am Dr. Sidharth Ramesh. I am a doctor by training in India, and I have been in the health IT industry for more than 7 years now. And you might know me from my YouTube channel. And today I have here 3 other esteemed panel members. So Pawan, why don't you go next?
Hey, Sidharth, thanks for having me. And hello, everyone. So I'm Pawan Jindal. I'm founder CEO of Dorina Solutions. My background is I am a physician by training, just like Sidharth did my MBBS from India. But it was a while back, and I think there's a new title for us now. I just saw it, Sidharth, for people like us, they're calling it ex-physician. It's actually getting an official title. We are not practicing, but we did. So I also have a master's in health informatics, and I say I got very early distracted or attracted towards the IT side more than the clinical side. Early 2000 was at the right place at the right time, got an opportunity to work with many of the healthcare systems, leading healthcare systems as a consultant. Then about 15 years ago, really driven by some personal events as well as a strong entrepreneurial edge, kind of started Dorina Solutions. So Dorina Solutions was originally started with a mission around patient engagement. But honestly, those were pre-MU, pre-iPhone, pre-Cures, era. So we learned It was not really ready for it, so we had to pivot. We built an EHR, we exited it. But over the last 7 years, we have been very focused on FHIR first solutions around regulatory, around consumer mediated exchange, and then recently a lot around CDS. So work a lot with APIs. So was very interested when Sidharth brought this topic and looking forward to this discussion.
Excellent, Pawan. So, Dr. John, why don't you go next?
Yeah, hello, I'm Dr. John Powderly. I'm an oncologist here in North Carolina and the founder of Carolina Bio-Oncology Institute, which is a phase 1 research clinic. Our claim to fame is we have developed over 170 phase 1 studies over the past 2 decades, of which 12 drugs have become commercially approved by the FDA. So our interest is in clinical research trials, and hence, therefore, clinical structured data, and hence, therefore, big fans of the momentum with FHIR and openEHR and trying to use these clinical standards for the future of really good clinical research. The cure for cancer is going to depend on good clinical research, accurate data, structured data, and interoperability. And we're learning from the legacy problems here in America, how unstructured and unorganized we are with our oligopolies and not really interacting very well with data transfer and interoperability. So I'm a big fan to fix and change that.
Excellent. That's Dr. John Powderly, literally curing cancer. Yes. So, Jason, why don't you go next?
Sure. Okay, thanks for having me. So Jason Klopinga, I'm the founder of Fasten Health. My background has been as an engineer. I've been designing and building HIPAA, SOC, PCI, FedRAMP compliant architectures for over 10 years at this point. I started Fasten as an open source personal health record app. I was trying to solve a problem that I had. I was diagnosed with a medical issue that required me to manage my own medical records that were split across a half dozen healthcare institutions that I had to deal with on a fairly frequent basis. And so that kind of led me down a journey of understanding how these health systems store medical records, understanding how they lack interoperability in some cases, they don't communicate with each other. And as a patient, it leads to lots of gaps. And in some cases, duplicate blood testing, duplicate imaging, pretty significant downsides to this lack of the communication between trusted providers, right? Trusted advisors for your health. And so I ended up taking a lot more control of my own medical records, built an open source personal health record app, and then eventually transitioned into helping patients share their medical records with other organizations that they trust. So personal health record apps by clinical researchers, all these AI startups that are trying to build healthcare agents, none of them can communicate with these national health information exchanges. And so we needed an alternative. And I was able to thankfully find the Cures Act on a rule that basically opened the door to patient access APIs, which I think are the most incredible foundational change in the healthcare space that I am aware of. And so I'm just incredibly grateful for that and very excited about what that basically means for patients.
Excellent. So again, this is from the comments. So Laura Lanford says, +1 to quality of the data being a critical component of the quality of healthcare research and the cure that comes from it. Definitely agreed. And so let's talk about, I think we are all on our own journeys and it had to start somewhere, right? So we faced issues with the existing infrastructure, or it was just what was the problem with the legacy system or the EHRs that we had? So why don't you, I think, Dr. Powderly, why don't you start off with, as a practitioner who is in the, you're a practicing physician, you're a researcher, what did you feel was lacking with the existing EHRs?
So great question. When I started my practice about 20 years ago, I had been at a prior practice and hospital systems that were all paper-based. So I thought I'm going to be the most progressive new young doctor with a new practice, and I'm going to start electronic EMRs from day one. Borrowed a couple $100,000 from the bank to get the newest, best of breed software. And at the same time, the hospital systems across the street were all becoming electronic as well. So I thought this is the future of America. We're going to be interoperable, and I'm going to build my research clinic on structured data. But I realized you have to buy different softwares for different components. A billing system is different, which is different from a pharmacy system, different from a clinical trial research system, from an EDC, different from a LIMS, different from a research lab notebook. So all these different systems, turns out they don't relate. Even though they may tell you they relate, they don't relate. So the cost of interfacing, this is just the outpatient setting, the cost of interfacing all these were tens and thousands of dollars in each direction. So even though I had the best of breed of everything, being able to interrelate them and the interfaces were incredibly cost prohibitive. Then at the same time, as the hospital systems became digitized, which the excitement was enormous amongst all the physicians. As we learned both Epic and Cerner systems years ago, 15 years ago. There was a lot of excitement, but then as we took call and had to admit patients and build different templates, we learned that if you're not living in it all the time, using it all the time, the curve to use it efficiently, like just as an outpatient doc admitting a patient maybe every other week, that was also, the learning curve was so difficult. It was like 200 clicks to admit a patient, another 200 clicks to discharge a patient. And the data wasn't that structured either. So we really started to rely on the hospitalists to do all the admissions and discharge. And we were just the consultants who would write one note, unstructured, that's about it. So I think there was a lot of excitement and just with a total crash of disappointment. And then I'll say quickly too, and then Medicare tried to put out standards to make it, quote, easier that the EHRs would interoperate, which when Medicare tries to intervene with something in the federal government, they made another 100 clicks to do more things that were required, which is, do you smoke? Do you not smoke? Did you get your vaccine? Do you have pain? Do you have a safe environment? I mean, good intentions, but it got to be so unruly to even be able to do that we found ourselves having to go off network with Medicare, off network with insurance companies, and really had to focus as an outpatient, and even had to deal with the hospital systems mainly through the hospitalists. So I'll pause there, but I think that's been a huge, it's been a huge letdown. What was the intention to where we have become today?
The regulation was meant to make things simpler, but it ended up making things a lot more complicated from the provider standpoint. So I think we'll hold on to that. We'll come back to, Pawan to answer what's actually going on the regulatory side. But before that, Jason, from the patient's perspective, what do you think, happened with the regulatory side? Did the government succeed in making patient access ubiquitous?
I think the short answer that everyone here can agree on is no. I think there's a ton of movements in a positive direction, but the gray areas in the legislation have basically provided numerous, let's say, opportunities for health systems and vendors to basically block patient access. So even though the intention of the patient access APIs, the Cures Act final rule, on paper is basically to open up the ability for patients to access their own data and for trusted third parties that the patient wants to give those medical records to access to have access to these medical records. In practice, there are numerous ways in which organizations can block that. And it starts from the most basic to just not providing adequate documentation for developers and application developers to actually interact with these APIs, and then it goes all the way to the legal side, where lawyers at big firms will basically just say, no, the way that we read the legislation, it doesn't align with let's say the common understanding of how it works.
Right. So coming to the legal side, right? So Laura asks, are you referencing the 2019 FHIR mandate from CMS, right? So Pawan, what can you tell us? Like, what's been going on? And, what is the state that we are in right now?
Yeah, so when I hear Jason and some of the discussions that we have had, I see kind of both sides of it. We work with like multiple EHRs, which we actually help them meet some of these requirements. We have been an EHR ourselves. We have kind of partnered it, and I always like to start with this as Jason. I mean, we feel I have personally felt actually that frustration, and as I said, is like when we had actually created our company, it was based on one of the issues we had just getting patient records. It was actually me, like we were pregnant with our first son, and my wife was actually having a very severe like morning sickness, and we had to travel a lot, so we needed to carry our records, and we'll go into the ER room and we are telling them, hey, this is what we need to do, and they're like, no, we need to get a copy from your physician. And it was so frustrating. So, and then 15 years later, we have this regulation which is so well written on paper. I mean, if you go into the rule and you see the thought that has gone behind it, it's amazing. I mean, like, we talk over so many people from outside the country. Oh my God, your Cures Act rule is so well written. They are adopting it. They are using it. I think the problem basically becomes in there is, and this has been since the meaningful use days, is like when the regulation comes out, the EHRs take it and say, what is the minimum required to check the box? And they just check the box and they keep doing that. And I hate to say this, there is horrible execution from our government to follow up on those regulations. I mean, if anyone has not read it, the blog from Jason that was out there that showed, the one that he just talked about how people are circumventing the problems. I really feel is that if everyone followed the intent of the regulation and could close some of the gaps and there was faster execution, we have an amazing set of regulation. But the fact remains, unfortunately, it is being executed horribly. I mean, the HTI-2 that is written right now, you read it and you think about it, how much thought went into writing that. But now people have just lost all hope. Is like, because, I mean, they'll just start talking about how to check the box. So very, very sorry state of state. But I want to just say this is like the problem is in the execution. In many ways, the EHR is basically avoiding it. But then last, I also think that the patients are not demanding enough. We give up so easily. Go back and ask for it is like, and not like, okay, hiring the lawyers to go and ask for it. I think Miki Tripathi and others have been saying this. We need to set an example. Let's create those examples and give it to them. I think you go there, you say, okay, I'll take a paper record and I'll move on. So if we can, it works both ways. I think that's kind of some of the places where we have to fix it. We can't just say that we can't change it, but like that's at least how we see it.
And for those who don't know the blog by Jason, you can just Google how to ignore information blocking like a pro, and the first result that you get will probably be Jason's article. So Jason, what can you attest to what Pawan is saying? Like, are EHR vendors just checking the boxes here, and what has been your experience building a PHR which pulls data from multiple sources?
Sure. So just to provide some context for how many institutions that we currently integrate with, Fasten connects to about 35,000 healthcare systems by integrating with approximately 40 EHR platforms. And so we've done a lot of work. We've talked to a lot of EHR vendors. We've integrated with their APIs. We've looked at their documentation. We've talked to their support teams. And this blog post is basically just a summary of that experience. Again, to kind of provide even more context, for some EHR vendors, a developer can access medical data, production medical data for real patients within 24 hours, start to finish. For others, the process has taken us 11, 12, 13 months of back and forth email communication and delays. And so that just shows, and that's only the systems that we actually have in the end connected to. There are numerous that have just straight up said, no, we're not going to allow you access. And Fasten has had to go down the route of filing information blocking complaints, which we've posted publicly. It is an incredibly frustrating, time-consuming, tedious process to integrate with EHR vendors. And the fact is that there's approximately 300, I think, active EHR vendors in the US. Approximately 300,000 health systems would have to integrate with. And so when you start integrating with these platforms, for a regular just a regular organization in general to create a comprehensive medical history for a patient, it's unreasonable. And I think that is the most frustrating part of this, right? Like Pavan was saying, like it's basically the intention is just so good. I think for a patient to have an alternative mechanism to access their medical records, not to have to drag around a file folder full of paper records from one institution to the other, or be given a CD or a DVD containing their imaging data, right? I don't even have a CD player. I couldn't use any of that. And so it was just an incredibly frustrating experience. And so this ideal world that we all kind of want to live in is, hey, there's an app that I can pull up. It has all my medical records from all the institutions I've been to. And at a glance, I can immediately find the medications that I'm on or a copy of my clinical notes. And the fact that, you know, an app developer who wants to build that future would have to potentially integrate with 300,000 health systems, different API endpoints, that is mind-blowing. And I think that at the very minimum is the biggest problem. But then you can go deeper into the actual, let's say, various mechanisms that the EHR vendors themselves can put barriers in place, right? So I mentioned earlier documentation, sure. There's also just implementation details around not creating test environments for developers. They can delay the integration process in numerous ways on their side. And then one of the worst things that these vendors can do is basically put barriers in place where they require the patient themselves to take an active role in the development of the application. And that just puts a lot of pressure, not only on the developers, but also on the patient themselves. And they're not even sure yet if this is going to be valuable, right? You talked about the fact that patients aren't, let's say, aware that these apps exist. They're not pushing for, the patient access APIs. And that's partially because there's no, this is probably not the best term here, but there's no killer app for patient access APIs yet. There's a couple of organizations that are really, really trying, but the thing is patients aren't aware that these exist. They don't understand in general that there's all of these benefits of getting access to their medical data electronically. And I'm hopeful that, there's going to be more market penetration for some of these patient access apps, but it's just so early right now that they're just not aware.
Right. And again, talking about the killer app, right? I think when Apple announced that it was integrating with hundreds of health systems, people were like, what? Is that real? But apparently that's not enough for people to open up their systems.
I think the interesting thing about the Apple Health kind of integration is Apple did a lot of work to actually put pressure on health systems and EHR vendors to actually, some of the largest ones, to actually, open up APIs, which is fantastic. But then they kind of stopped and they basically said, all right, we're going to make it very easy for patients to pull data into the Apple Health HealthKit or the Health Vault effectively. But we're not going to actually create a meaningful or a functional, let's say, user interface for that data for patients. And so they were depending on their ecosystem of app developers to go ahead and create that experience. And I think that's fine and fair for what their intention is, right? They're creating a better ecosystem, a better foundation for their developers. But at the same time, patients want more than just a tabular list of all the medications they've ever had. They want more than just a tabular list of all the conditions they have in their medical history. They want to be able to ask questions of their medical record. They want to be able to find things very quickly. They want to see trends and graphs and have medical terminology translated and understand and converted to something that is easier for them to understand as patients, right? These clinical notes are usually written for doctors, by doctors or other doctors, right? And so when you actually look at the content of a medical record, in some cases it's not very patient friendly. There's a lot of jargon, there's a lot of medical coding that is not helpful. I think when a patient's trying to understand their own health And again, I think Apple did a fantastic job, but I think we're still seeing the lack of a killer app in this space.
Yeah, I guess it's the chicken and the egg, right? It's like, okay, is the app waiting for the data, or is the data like not available? So, I mean, yeah.
Like, we have a question, like, how useful was Apple's approach without a ubiquitous data standard? Asking sincerely. And I think it used FHIR, like Apple used FHIR. They
Yeah,
didn't really.
actually they used, that's why they did go. I mean, actually, that was one of the two things that they say happened, like what really made FHIR like FHIR, right? Is like one was the Cures Act, and second, Apple basically announcing it, and it suddenly brought it into the consumer space. So I think they did actually go with the right approach, but like it didn't catch up like as much as you wanted consumers, and like we would have hoped is like by now there would be a whole marketplace of better and better apps. It's not happened that fast.
Right, right.
I think one of the interesting things that, at least this is my personal opinion on this, but I believe that the lack of a killer app is partially due to the fact that it's read-only access. As a patient API, all we can really do is pull medical records from these various institutions. And as a patient, that's great because now you can see all your medical records in one place. You can see mistakes in your medical records. You can, generate nice, friendly user interfaces and do the medical jargon translation, like I was mentioning earlier. But one of the most valuable things that you can do with your medical records as a patient is put them in the hands of your practitioners, put them in the hands of a doctor that's treating you for some condition. And the ability, or the lack of ability for these personal health record apps to, let's say, push data into the EHR of the practitioner means that at the end of the day, we still have to generate a PDF or print out a copy of the medical record that we've summarized and bring it over to the doctor. And so I know that there's work being done under the HL7 work group, a couple of different work groups around patient contributed data. But I think that is when you will be able to see a much more, I think, meaningful a much more meaningful kind of implementation and a real killer app at that point.
Yeah. That's a really great point, Jason. And again, we are actually working on, there's a group on Argonaut for CGM where they are pushing glucose data back to the the providers, and that's pretty active right now. That's kind of where they're starting. It's not just about the glucose, but it's about pushing data back. But I would also like to add another point that we are seeing a lot of it. Like one is obviously push data back to the EHRs. But one thing that we are seeing is this consumer-mediated exchange pushing data to like registries or clinical trials. We have had number of cases where people have come to us. They are actually building solution like hosting on our where they're actually making it easier to aggregate patient data, like launching a clinical trial. So I think that even the read-only data has value, but honestly, it's not creating that value for the patient as you're talking is, but definitely it's making the data movement easier. It's much easier to get data from patient in many of those scenarios than you had to go through providers and go through all the BAs and everything else.
I don't know if I would agree that it's not providing value to the patient, because the patients that have used my personal health record app, like the kind of conversations I've had with them, they've been incredibly interested in contributing their data to clinical trials, right? For them, there's a possibility of a treatment or potentially a cure for their disease. That is something that is it provides a lot of hope and a lot of value for a lot of patients. And so, yes, at the end of the day, the data is going to a clinical trial organization that's going to use it and makes their, let's say, intake process and data aggregation process a little bit easier. But I think it all comes down to the fact that it is helping patients.
100%. Yeah. When I meant to say like when you said like having them the killer apps or being able to write it. I mean, maybe that's not meeting that, but 100%. Patient is always at the center of it, right? So it's like definitely the data flowing and they being the the controller of the data helps a lot overall every use case scenario. Absolutely.
So I think we have a very interesting question from Michelle. And again, this is, can you provide a summary of the challenges with legacy databases in general? So again, Michelle, we are talking about the EHRs and how they are limiting access here, right? And again, as Jason said, maybe the reason why we don't have a killer app is just because like they don't allow for a killer app to exist with the APIs that we have today, right? And it may be a chicken and egg problem, but then we are seeing API first clinical data platforms come up as a solution worldwide. People are adopting, they're trying to separate the whole EHR into a data platform, and then they have apps built on top of it, right? So I think we are transitioning into this thing. We are seeing people transition from like one vendor who has like literally everything to multiple smaller applications that are operating on a unified data layer. However, like this, what do you think? What's been the US side of this story? What's been going on?
So let's put a little context in here, just to kind of zoom out a little bit on the Cures Act, right? And what we kind of started the discussion, it was the patient APIs. What we don't realize many times is that the EHRs and the way the act is written is it's patient APIs, provider APIs, as well as system APIs. So it's not just about access to the patient. And when you start looking into the provider API side, which is like a lot more impactful, there's a whole different kind of areas in there. I mean, it really brings back to the idea of like what made iPhone an iPhone. It wasn't the iPhone, it was the apps on it, right? So if I am having and Dr. Powderly had to step out, but like this was one of the idea behind the whole FHIR was that if there is a feature that is not provided by my EHR, I'm a provider, I want that feature, I can just say there's an app for it. And there is a market for it. I can go find my best app and it just works as a plug and play with my solution. And then, I can kind of continue with it. So I think a lot of that frustration has also been with that those APIs are also very limited. Even according to the regulation, it was the patient API. We always see it as, the read access, but we work a lot with the provider APIs as well as the system APIs, and the potential that they have with, opening up other things has really been very restrictive.
I think it's almost as if what if the iPhone comes out and says that all apps can only display black and white, and they can't use the camera and they can't make calls. I mean, that would be crazy, but it's exactly what's happening in the EHR market today, right?
It's like many people don't realize, right? The first version of iPhone did not have any apps. I mean, it's hard to imagine that was the first iPhone, but that was the okay EHR days, years ago, but it's not okay today.
Yeah. Jason, what do you think? What do you think the future of this is supposed to look like? From a patient point of view.
Oh, that's a very interesting question. I think if you ask a dozen patients, you'll probably get a dozen answers, because there's different levels of first interest in your own medical record, right? There's a very interesting graphic that I've seen where it kind of graphs patient age against their interest in their own medical record. And it turns into like this double horned image where when you're young, you might be interested in your medical record primarily for the quantified self movement, right? You're tracking your own health and how far you can run and things like that. And then as you get older, you're healthy, but you're busy with work and life and kids and family. And then as you get older, you might start seeing medical issues, chronic illnesses, things like that. And then health becomes a lot more important. But I think the thing that really kind of draws all of that together is the fact that at the end of the day, what I've seen is that patients really want to, when they're engaged with their own health, they want a place that they can trust to store their data. They want the ability to make it easy to give that data to organizations that they trust, including their doctor, but clinical researchers, other uses like that. And they want something that will help them understand their own health. To be quite honest, it's not necessarily XYZ feature or pretty graphs and things like that. It's how can I health is such an esoteric, fuzzy kind of concept. It's for a lot of patients that are suffering from illnesses. It's just something that they have a lot of difficulty grasping all the different parts of their health that contribute to a healthy lifestyle and to the medications and how all of that kind of comes down to affecting their day-to-day lives. So I think what it would really end up like an ideal personal health record app would be something that just really helps the patient understand their own health and makes it very easy for them to take that data that's relevant and important and give it to organizations and individuals that are helping them manage their own health, right? And the other thing that we didn't even talk about is how personal health record apps are valuable not just to the patient, but to the support system around the patient, right? The caregivers, the family members, they also have a very important part to play in supporting a patient that is suffering from some sort of illness. And so getting that data in the hands of the right people with the right context, I think is incredibly important, incredibly valuable.
Absolutely. I 100% agree. Like there is a lot of benefit to the patient just getting a hold of their data and having like direct access. But as you would see, we have a pretty critical audience, so they ask a lot of, so there's Sidharth saying that patients will have customized insurance rate hikes once they start sharing more access to their data. So for example, let's say insurance providers start wanting more and more out of the patient data. And then what if that ends up harming the patient, because now people will mandate that the patient share their information before they give an insurance policy. So I don't know, is this a double-edged sword that we are getting into, or is this claim or is this fear unfounded?
100%. So the interesting thing about the Cures Act, and we could talk about multiple double-edged swords under the Cures Act, but one of the, let's say, most powerful things about the Cures Act and the most dangerous things about the Cures Act is that it's leveraging patient access to their own data. So as an individual, I can always stand on the street corner and tell the world that I have diabetes, a heart condition, that I'm pregnant, and no one can stop me. It's my own medical information. What the Cures Act allows is for the patient to take those medical records, pass them on to a third party, and they don't, and it's all done with the patient's consent, right? They're the ones shipping those records. That means HIPAA doesn't technically apply to those medical records. Now, there are other types of legislation that does kind of come into effect here, but at the end of the day, it's not protected under HIPAA. And so, yes, there is the potential for abuse. There's definitely the potential for organizations to leverage and misuse the trust that patients have in those organizations. And the interesting thing is, the only thing really protecting those medical records once they're in the hands of a third party is the privacy policy and the terms of use of that third party organization. And I don't know about you, but I very rarely read the full terms of use and privacy policies of companies that I trust with very, very important bits of my information. And then to go even a step further, right? Those are living documents. Those are documents that change over time as the business evolves. And so, yeah, I think there's definitely potential for abuse. There's definitely potential for misuse of that information. At the same time, I don't think that it is fair to basically not allow the patient to have, there's a term for this, but basically to put up barriers and not allow the patient to have control of their own medical records and give them the autonomy to use those records how they see fit. I don't think that paternalistic view of patients and medical records has a place. I think that we need to trust that patients will do the right thing. They'll put in the time and the effort. If they're going to go through all the effort of actually getting their medical records, they're probably going to go through the effort of understanding what the repercussions are of sharing that data. I think a lot of people view medical records as incredibly personal, incredibly private, and I don't foresee, at least anytime soon, people just sharing it willy-nilly with organizations that they don't trust. But that's not to say they shouldn't vet organizations that they trust, for sure.
Owen, what do you think? What's your take on this?
Yeah, and I think the question actually was targeting like a little bit different, is to say that is there a harm to the can they be abused in a way if the patient shares it, and then the insurance is using it to basically negotiate a price. So I'm seeing what is the alternative of this. See, that's always a good way to look at it, right? Okay, if you are basically applying it, you anyway have to fill up the forms, right? So if you're not disclosing any of this, so how it's not any better. What this is really doing is again, giving you a simpler way to share that data. Will basically these insurance companies and others write algorithms and other things to make it smarter and other thing? I mean, yeah, but then I think that there will be other ways to manage it. So there's always a downside of it, but like again, you have to look at the bigger benefit, and like the bottom line here is that patients having access to their data makes it easier to share that data, makes it about it. So will there be bad actors that will try to use it for wrong purposes, for increasing the claims? Yes, but I'm sure we'll get up smarter with how do we counter that. And at the end of the day, it is important to understand that the patient still controls. So if there is a specific mental health or some other issue that is sensitive, or the caretaker does not want to share it, there is nothing in the law that requires them to share it. It's as good as withholding information, it there. So I don't think, again, whoever asked that question is like, it's a very valid question of the concerns of how the data will be misused. But I think there is no better person than the patient themselves to manage that data. And I think that's kind of what we are trying to get to here.
Right. And I really like this point that Jason brought up, which was this is a paternalistic view of, why would you restrict access just because someone can do harm? That's like, exactly. people should not talk because by talking you will hurt someone, right? You might hurt the feelings of someone if you say something mean, right? So and I think that applies not only to patients but to almost all the stakeholders in the healthcare enterprise. So when a big EHR like Epic blocks access to another application that a practitioner wants to use, I see it in a very similar vein to what Jason was talking about when a patient can't access their own records and do something meaningful or useful with it, right? So, yeah, I mean, that's a very good point by both of you. So, what do you think? Do you think so? API platforms, we've tried to take a step forward from the existing model of EHRs being regulated by regulation, and they are basically just checking the boxes right now, right? So they're not really implementing any meaningful APIs, and they're not opening it up because, well, the implementation of the regulation is not good enough. But then outside of the US, we are seeing people adopt these platforms because of the features or because of the reason. Many people say a patient's data needs to last at least the lifetime of a patient, whereas applications and big enterprise applications usually get replaced every 10 years, right? So the patient lives for 70 to 80 years. So do you think there is any scope in the US where people come forward and then they start adopting API first data platforms instead of these big monolithic EHRs? Are we seeing any scope of that in the US right now?
Yeah, so if I can take my take on this, is so again, Sidharth, the concept that you're talking about is BYOD, bring your own data with the patient, where they carry the data. And it's funny, if you go into some of the history, before 2009, we used to always call them EMRs, and then they went to EHR, and the official definition of EHR was that it is an electronic health record of a patient, a longitudinal record. That was the whole regulation was based on how can you build connected patient records, where EMR is just considered basically a single facilities record. So that way, EMRs are what are at facility, and we want to move towards an EHR model. And is the solution to that now is that, okay, we go start building completely new APIs, new healthcare platforms that are completely based on APIs. So I feel, again, there is a difference between just building an EHR and what we are calling as health data platforms, because in some cases it's like transactional versus analytical or clinical decision support or clinical research or many of the other things, right? So when you talk about EMRs, right? EMR is not just about technology. It's a whole support system. How do you get a hospital to start it? How do you use it, right? How do you make sure it's 24/7 available? So it's not that easy to, kind of just flip that and say we go with the platform. So I've been through that journey, like, couple of times, right? Like being a CTO of an EHR company, having brought an EHR company itself too. So I feel there is a way that these APIs need to be enforced more, where they become like the alternate source of growth, right? It's like one of the ways, like, okay, where we can build these apps more and more. Obviously we are seeing a very big trend of now these completely FHIR-based EHRs coming in there. Honestly, we provide a platform on which many of our partners are building that. But I'd like to just caution that is, if you're truly building what is called as an EMR, which is to take care of daily patients and everything, that's a lot more than technology. That's a lot more than connected. But if you're talking about building healthcare platforms that are, for other purposes, absolutely API is the way to go. And that's kind of what we heard from, Dr. Powderly there too. That's definitely in there. So somewhere in there's a middle ground where the current Epics and the Cerners and everyone else will have to be supporting more and more APIs so that we can truly build these healthcare platforms till we are really ready to have large scale implementations of, like the next Epic that is fully API driven. I mean, that's nothing in there, just a box. That's what I feel.
Right. Like, so Anand asks, like, just wondering, with so many challenges, what is the API advantage now in reality when there is no open mindset from various stakeholders to use and expose APIs to their data? Right. And again, it's just funny to talk about this right now, because like Jason is on one side, he's like, hey, EHRs, please give me the data. And Pawan, you are on the other side on the, you're building EHRs and you're helping people open up these APIs. So, Jason, you definitely have a lot of value if Pawan were to just open up all of the APIs on his EHR, right?
Agreed. Well, I think personal health record apps in general would be incredibly happy. They would be popping up all over the place if not only the vendors made it very easy and seamless for developers to enroll, but also they were able to do it kind of en masse, right? They were able to integrate with 300 EHR platforms without having to do a significant amount of manual work. I think there would be dozens, hundreds, thousands of very, very popular personal health record apps, because then you would start seeing, instead of just a personal health record app, you would start seeing developers create a personal health record maybe for a certain type of condition or a certain group of people, right? You'd see a lot more specialized kind of experiences, right? And you already see that in the developer ecosystem, where developers are building something for people who are suffering from chronic illnesses. Like each type of chronic illness will have its own kind of application, but in general they don't or aren't able to leverage medical records because it's just so difficult and time consuming for them to do so. And so you would actually start seeing medical records potentially be leveraged and used within those very condition specific or just specific types of communities. You'd see them being leveraged a lot more heavily. And I think that can only really benefit the patient at the end of the day. I feel like there are definitely barriers to there's reasons why EHR vendors and health systems are protective. And I agree with them. I understand it makes a lot of sense. At the same time, the government mandates have basically have put certain requirements on vendors and health systems to open their doors. And the fact that they are able to still put up so many barriers and effectively work against the intent of the legislation is concerning to me, right? The law passed years ago. I think it was 7-8 years ago at this point. Compliance has been mandatory since December of 2022. And yet when I reach out to some EHR vendors and health systems, they're hearing about the APIs for the first time. They are unaware, or they just aren't ready to actually deal with an actual developer who wants to integrate with their platform. And that's the best case scenario. Though the worst case scenario is they are absolutely pushing against and trying to find ways to deny me access. And that is just not, I think, good for patients at all. And it's definitely against the intention of the legislation.
Right. And again, I think this is starting to create this longitudinal health record, right? Like, so the need for a longitudinal health record where the patient's data, just flows between different systems and someone has access to this. It's currently probably only possible through patient-mediated exchange. And like the patient first accesses this information from different EHRs, and then the patient is the one granting access to different other EHRs. So I think, I don't see any other way in which we'll get to longitudinal patient health records other than by opening up these APIs.
So, well, I think TEFCA and HIEs probably have a place in the conversation at this point, right? When you talk about, creating a longitudinal health record, I think they are the, let's say, de facto mechanism that health systems have been using to access medical records for patients for decades at this point, right? The problem with HIEs, the problems with maybe we won't touch on TEFCA yet, but the problem with HIEs is that they're limited to a treatment purpose of use, right? You need to have a clinical relationship with the patient to effectively query this national network that would respond with, ideally, a full copy of the patient's medical history, which again is great for practitioners that can afford to connect to these networks. But when you talk about smaller other practices, when you talk about these other secondary uses that are incredibly valuable to the patient, to their care, they're not an option. And so there has to be an alternative mechanism. There has to be, in the words of Brendan Keeler, there has to be another paved path for patients to access their own data and for patients to give consent to other organizations to access that data.
Yeah. And TEFCA does have a use case for the patient access to their own data, but we are already hearing all the issues and everything. So that's one path that will go. We'll see. But I think it more than the technical, it's also easier for a patient to actually lead that path of getting the longitudinal data. And we'll see how TEFCA plays out. But that particular use case of patient having access to their own data to TEFCA, again, watch and see. Let's see how well it is executed.
That, finally brings us to clinical decision support taking, a turn now. And especially with new regulation coming in, there is a new wave of mandates going on. So what's going on here with, CDS? And do you think this will open up EHRs to expose more of their APIs?
Yeah, so I'll give a little context in here. Again, this is more US specific, is what's going on with CDS. And of course, I think we all know what is driving suddenly the high interest in CDS is the two-letter word AI. But last year, the ONC basically released an update to what has been called the A9 regulation that has been there from EHR from the start, where they replaced the word CDS with DSI. So it used to be clinical decision support, and it's now called as decision support intervention. And basically the idea behind that is that AI, or in general decision support, has potential to improve more than just clinical outcomes, a lot in the administrative, in the billing, especially with the AI application scheduling and everything else. So a lot interest right now in this DSI area, and it is a lot more because of the fact that the regulation goes into effect by the end of this year. So by the end of this year, all the EHRs have to upgrade their systems in a way where they should be allowing a way for the app for the providers to use third-party DSIs or third-party basically apps in their system. So again, the good thing here is excellent, regulation, well thought of, put in there. We'll see where the execution goes, but this is something that, we are working so closely with so many different EHRs, helping them. But what they have left gaps in that is like, okay, you just need to provide a way for an external app developer to provide, and integrate in it. But it doesn't say it has to be FHIR. It doesn't say kind of how it needs to be done. So some of those things that we have seen in like, those patient issues will probably come in there. So again, a lot to be seen, but it's the first step to say that the acknowledgement of the fact that maybe one side was patient access to the data. The other side could be enabling this demand for AI for providers and enabling the EHRs to enable that. But unfortunately, it doesn't actually clarify today that it needs to be the APIs and other thing, but that's the direction where HTI2 is probably going, and which we hope will go through, so that in the next year or so, we'll see a lot of movement towards this.
And like talking about AI, right? Like it's becoming easier and easier for people to express their intent and for that to be converted into API calls, right? So I think we've seen a lot of demos of this before where I think in the patient context, this is very, very important, where patients can like just easily query their own data and they can know a lot more about their health conditions, or even ask, like ChatGPT for a better diagnosis or an alternate treatment plan, right? I mean, we may be getting into dangerous ground here, but I think it applies equally on the practitioner side as well. Like now the practitioner, there is no necessity for him to use a user interface and like click on, I think Dr. Powderly, he has gone to attend to an emergency patient, I think. But he was telling how he had to do this click 1,000 times. Now, the only thing you need to do when you have AI is tell it like, hey, I want this done. And then it can get it done with the APIs available to it, if the APIs are available, right? So I think the only moat that the current EHRs or the current vendors kind of have is this workflow that they have done, right? Like the EMR or the different workflows that they have modeled. So I think with the rise of AI and with the fact that both practitioners and patients can kind of just do whatever they want, and all you need is like a source of truth that exposes as much API as possible. I think I want to answer that question that Anand asked, like, what is the API advantage now? That's like, I think it will be obvious in a few years when you can't do certain things with Epic or Cerner, but then you can do it with, like, let's say, just a FHIR server or an openEHR server that supports any operation. It's going to be night and day between like data platforms and just EHRs that expose some of this. So, I mean, maybe Jason or Pawan, you have some other opinion on this?
Yeah.
No, go ahead.
No, I was going to say, again, like, so the purpose of API is basically to decouple the use from the data, right? That's the whole idea, right? Okay, I have something, there is an idea. So to say that, okay, we can't just generalize it, but like, okay, to say the fact that if you can expose that data from the API, it's not restricted to the original purpose for which it was created, which was providing the care at that point of time. How do you basically make it to provide better care, to provide better research, to just follow up and not repeat the tests and everything else? So we have to think in, the terms of API and FHIR APIs as a broader part is like, okay, the idea there is that the data can be used for other purposes than what it was originally created. And that purpose is definitely going to be there, and that will come in there. Can the AI tell you that is something that you didn't know before? Or it can improve the process, or it can just improve the care.
And maybe what I would add to that from the patient's point of view is, like, every industry that has modernized and introduced APIs and standardization has been accelerated drastically by consumer applications, right, that are built on top of those APIs. In the healthcare space, there has not been as much, let's say, innovation on the patient side because there hasn't been APIs. And so I guess my answer to that would be that, what's the value in APIs? Well, like, we don't necessarily know, but there's going to be developers that are going to build fundamentally valuable, unique, innovative solutions in this space that we probably that we're not even considering at this moment, right? And I think that's the value of APIs, right? That when you have this API, when you have access to this data in a structured electronic format, it kind of comes down to how creative are you? How creative are developers? And what are the actual needs and problems that people are trying to solve? Because there's no longer this massive barrier in terms of legislation and in terms of access to the data. And so it kind of comes down to like the creativity of communities and developers and the problems that patients actually are running into. So yeah.
Yeah, I mean, very timely answer. I think Chatayam from the comments are asking, like, what benefits can third-party APIs or data platforms provide to EHR firms so they are incentivized to share? Right now, just using stick of regulation doesn't seem to be working. Thoughts? And again, I think Jason answered this beautifully. You don't know what's possible. Like, again, that's a vague answer, to be frank. But again, Uber wasn't possible before, like hundreds of other innovations before it, right? So yeah, I mean, we don't even know what's possible if these APIs aren't made live, right? And maybe you, Pawan or Jason, you could also take this question. But like right now, it seems to be the stick. Like, what is the carrot in this case for EHR vendors?
Yeah. So I mean, I'll say one of the carrot there is like, the providers getting that data back. And I think, Jason, you touched it when you said like one of the, the key components you're working. Everyone is looking at this, right? Again, the EHRs are basically saying is, hey, the patients are not asking the provider, so why do we have to keep, doing this? That's their excuse. What we are not seeing is like what we are not kind of telling about, like talking about is, if you share that data with the patient is aggregating. The next time the patient is coming in, all that pre-registration, all the data history that you have to find. I mean, imagine the power of just having that at the point of care being available to you. And this is not like a futuristic vision. It is happening in many cases today. Some of those patients kind of aggregating that data. And that's kind of the value back to the EHR is to say, hey, if you can start building these features, your providers will want these features. I mean, that's basically a feature, right? Is to say how we can do it. And that was honestly the intent of the regulation when they started with stage 1, stage 2, stage 3 was like, let's digitize, let's connect, and then let's start interoperating. So I think it's like as we start seeing some of the use cases that we have not seen in there, how the data becomes back to these providers, helps them provide better care. That will really be the incentive, how we can actually make it better.
Yeah, so really
Great.
unfortunate. Yeah.
Oh, sorry, go ahead.
Go ahead, Jason. I mean, I was saying really unfortunate that Dr. Powderly couldn't make a statement on this because he's been a very big proponent of, hey, as a provider, I just want to do my stuff. Give me access to the data, right? But go ahead, Jason.
I guess the thing that I would add is I think interoperability itself is the feature, right? From the practitioner point of view, as you were talking about, right? If the whole healthcare system is theoretically designed to help the patient, right? Having access to a comprehensive longitudinal medical record for the patient is incredibly beneficial to the practitioners as they're treating the patient. So interoperability from that sense, from that point of view, is incredibly valuable, and it's why health information exchanges have been around for such a long time. It's why there's been interoperability mandates much earlier than the Cures Act final rule, right? And so I think the only thing that's new, the only thing that's being requested here is, hey, this interoperability that is available and incredibly beneficial to practitioners, let's also open that door to patients, right? The work has already been done. The APIs are already there. The standards bodies are kind of working and iterating on this. Why are you putting barriers in place that are stopping patients from accessing their own medical records, right? And I think that's what I keep coming back to. It's not like a fundamental shift in engineering effort, at least for the most part. That's my opinion. I think it is going to have a potentially fundamental shift in the way that patients view their own data and think of their own medical history and the patient experience. And so that value add there is I can't see any reason why you wouldn't want to do that, right? Yeah.
And one reason would be to maintain a monopoly, but you don't want others to come in and take a revenue share of what you are doing. But this has been really great. I think the discussion so far has been excellent, and we've had more than 150 people join us. And thanks a lot to all of you for the wonderful questions. And maybe we can, any parting words or any parting thoughts from the panel members. I'll maybe look for some questions that we may want to answer.
I'll just say I've always says FHIR has lowered the bar. I mean, this is the time to get into healthcare. You have an idea, make it happen. I mean, the best ideas will come from the consumer, will come from a problem that you have faced personally. So, the more demand we have, the data APIs will be open. So if you have any idea, please just jump into and you have a little bit of coding skill, or join Sidharth's boot camp and, build an app.
Agreed 100%. Like there for such a long time, there's been barriers and there's walled garden around medical data, and the fact that now it's available and the patient can give you access to it electronically. And I think there is so much potential here for patients and developers to build really unique and valuable experiences. And I would just basically, double down on that and just say everyone should be looking at these APIs. The data structure of the APIs, it's all public. They're really well documented as a developer. And there are some reasons there are some things that make this difficult, but at the same time, it's getting better, constantly getting better. So definitely worth spending some time in investigating it.
Yeah, on a lighter side, I just had a comment which was like JSON, more like JSON, because you're liberating the data. But maybe you've gotten this before.
Let's just say as a developer with the name Jason, you hear JSON a lot.
Excellent, excellent. And thanks for all the questions from the audience. Been amazing. And, thank you, Laura. Thank you, Michelle. Thank you for the opportunity. Wonderful. To all of you, I think we had a pretty good turnout, and I'm pretty happy with the discussion. A lot of critical questions from the audience as well. And been great. I mean, thank you. It was unfortunate that Dr. Powderly had to drop off in the middle, but I still think we had a great discussion, and looking forward to having another one similar to this.
Absolutely. Thanks, Sidharth. Thanks everyone for joining.
Yeah, thank you.
Thank you. Bye-bye.
Take care.